cancer. A little about Dr. Subramaniam. He is a consultant and head of the department of head and neck oncology at the Sri Shankara Cancer Hospital and Research Center in Bengaluru. His medical qualifications are MBBS, MS General Surgery, MRCSEd, MCH, FICRS. He received the TransOral Robotic Surgery Visiting Scholarship from the University of Pennsylvania and the Fellowship Sydney Head and Neck Cancer Institute. Dr. Subramaniam offers a wide range of treatment to patients with neck and head cancer, including treatments like 3D virtually planned dental implant-guided reconstruction of the jawbone and facial nerve reconstruction. With a team of experts, he offers affordable surgical and non-surgical care to patients with disorders of the head and neck and focuses on quality of life. He is also a clinical scientist focused on improvements in existing head and neck cancer treatment. He's an investigator on multiple ongoing clinical trials and research which offer innovative treatment options to patients with head and neck cancer. He has a passion for community outreach in oncology and public health, specifically targeting low-income households. With his insights into the confluence of medicine, technology, social impact, and entrepreneurship, he is also the Bangalore chair of the All India Managers Association of the Young Leaders Council and the oncology mentor for the Indian Edison Accelerator Program Cohort 3. He also regularly contributes articles on health for the general public. Welcome to Health Live, Dr. Narayana Subramaniam.
Thank you very much. Thank you for the introduction.
There's one part of the introduction which I haven't said, which is about your musical background, but which I know, we don't want to delve into very much, but perhaps some other time we will do that. Dr. Subramaniam, this is a question which I ask to all doctors who are here, and since we meet all of them, there's news about the rise of COVID cases in some parts of the world, China, South Korea. What does it look for you in terms of the scare, the threat? This is some new version of the new variant of the virus.
So I think India was luckily spared largely in the third wave. And I think there were a few reasons for that. It was a largely vaccinated population. Luckily, we were able to get enough people vaccinated. And it's possible that we had antibodies from the second wave. Delta affected India quite badly, as we saw. But I think I'm not really a COVID expert myself, but from all of the literature that we're reading from the people who are experts, is that, COVID is going to be something that we live with. It is going to be something that may be a slightly more dangerous version of the annual flu season that we see in the West. There may be, new strains. We may have to get repeated boosters. But I think what we've seen in the, as healthcare practitioners is we've neglected a lot of other diseases as a result. Cancer is a perfect example of that. We've been afraid of COVID. Naturally, we've lost a lot of people. A lot of people have suffered. But now as doctors, our message is, if you have other health problems, you have cancer, you have diabetes, you have hypertension, you have to go and get those managed. So I think we need to stick to the basics, the fundamentals of, wearing a mask, personal protection, washing your hands, those kind of things, social distancing. But hopefully the worst is behind us. But I think that we have to look at other aspects of our health and we have to move on with, life to some extent.
Absolutely. The thing is that we have to move on with life, and get back to business as usual. But for people like yourself who are meeting, patients of all types, and if somebody is coming in for treatment with you, then it becomes all the more challenging, right, to brace yourself for a possible threat. So what do you do to ensure that you're warding off a possible threat?
So I think for us, from the time we knew what COVID was, it has been universal precautions. For us, we're not able to test each and every patient. Some people might be in the incubation period, so they might be infectious, even though they don't test positive. So we've just had to take universal precautions. But the thing is, as doctors, especially as people who treat cancer, we can't afford to be scared. We can't afford to, not go out and treat patients, because for the vast majority of patients, cancer is going to be worse than COVID. So, unfortunately, it's been business as usual for us for the last couple of years. But we've seen for a lot of our patients, once they contract COVID, their treatment schedules get disrupted. And as a result, their cure rates come down. So, so what we have done now is we've removed routine preoperative testing for COVID. So unless a patient has symptoms, we don't test them, because we may have a lot more asymptomatic patients, is what we saw in the third wave. So we are trying to go back to, what is standard of care. We're trying to be less afraid. We have to take precautions, of course. We have to protect ourselves, our staff, and all of those things. But if you have issues, my message is please come into the hospital, please get them sorted out, because neglecting them can be very, very costly. We've lost a lot of patients because of that. So we don't want that to happen again.
Right, absolutely. I don't think we need to neglect one for the other. For a short while, the big C, as cancer was always called, had become COVID as the big C. But I guess the attention has to be back on the basic afflictions that a person might have. Thank you once again, Dr. Narayana Subramaniam, for being here. Over to you for this short presentation that you have. And those of you who have questions, as always, please put them in the Q&A tab with your gender and your age, so that Dr. Subramaniam is able to answer, taking that into account. So please put your name. If you don't want it, you can keep it anonymous, but suit yourself, and please put your age and your gender. Thank you very much, and over to you, Dr. Narayana Subramaniam.
Thank you very much. So my presentation hopefully will be short and sweet. I'm just going to give you an overview of what oral cancer is like. Is my screen visible?
Yes, it is.
Okay, so
getting a little cut from the left, but it's okay. We'll see how it goes.
Okay. So my talk is going to be on oral cancer. I'm just going to give you a rough overview of oral cancer, give you some details, and then hopefully you'll have some questions and we'll have an interaction, right? So this is the outline of my talk. This is what I'm going to be covering. So number one, oral cancer, an Indian problem. So why are we talking about oral cancer, right? So, when we were approached to do this talk, I wanted to specifically talk about oral cancer because April is Oral Cancer Awareness Month. So it's not something that a lot of people know about. If you talk about cancer in general, a lot of people are aware about breast cancer, they're aware of ovarian cancer, prostate cancer, But when it comes to oral cancer, people are a little bit foggy. They don't know what exactly it means. They don't know how you get it. The awareness is still low. So is oral cancer a big problem? Yes. So oral cancer is a very big problem. India is considered the oral cancer capital of the world. So we have nearly 150,000 new cases every year. Why India is called the oral cancer capital of the world is because we have a high number of patients with oral cancer every year, right? So why do we have oral cancer in India? The reason is tobacco use. Unfortunately, the vast majority of oral cancer is associated with tobacco use and alcohol. So the last global survey that was done showed 1 in 3 adults in India use tobacco in some form. So in the West, we have cigarettes, we have cigars, whereas in India, we have multiple forms in which we use tobacco, some very innovative ways to use tobacco. So we have this smoking tobacco, which is, burnt. So you have cigars, cigarettes, BDs, and you have the smokeless tobacco. So the smokeless tobacco is what we call chewing tobacco, pan, khaini, gutka, zarda. You have snuff, which is inhaled into the nose. So because of this, India is the oral cancer capital of the world. We have a lot of oral cancer. So what is oral cancer exactly? So oral cancer or mouth cancer is basically when we get tumors inside the mouth, right? So when we say the mouth, you can look at this picture here on the side. There are a lot of areas in the mouth, right? So most commonly, the tongue is involved. You can have the lips involved. You can have the undersurface of the tongue, which we call the floor of the mouth. You can have the gums or the jawbone. You can have the roof of the mouth, and you can have the cheek, right? So these are all the areas that can be involved with oral cancer. So how do you get oral cancer? Around 80% of oral cancer is linked to tobacco use in some form. What people think, unfortunately, is that you have to use tobacco for a long period of time to get oral cancer. People think that it takes 20, 30, 40, 50 years to get oral cancer. But what we are seeing, unfortunately, is a much shorter duration of tobacco use is enough to give you cancer. So we are seeing an explosion of oral cancer in people who are much younger, sometimes as young as 20. And the reason why that's happening, at least the theory that those of us who practice oral cancer treatment have, is that it's because it's being combined with multiple other harmful substances. So you have areca nut. So areca nut on its own causes cancer. When you add it to tobacco and alcohol, probably accelerates cancer. We also have additives like slaked lime, what we call chunam, that also irritates the cheek and the tongue, and those can also cause chronic irritation and cancer. So outside of tobacco and alcohol use, you do still have 10 to 15% of patients who say they have never touched tobacco and alcohol, but they still get oral cancer. So how does that happen, right? So the other causes of oral cancer are sometimes you can have chronic trauma. So there can be an injury on the tongue, on the cheek, on the lip, from a sharp tooth or an ill-fitting denture. So that's one way of getting it. You can also have oral cancer when you take immunosuppressive medication. So if you had a liver transplant or a kidney transplant, you take immunosuppressant medications over a long period of time so you don't reject your organ. So those medications have a higher risk of oral cancer. It can also be associated with HIV infection. So those of us who are living with HIV have a slightly higher risk of oral cancer. And also, if you eat a lot of spicy food, you have a lot of chronic mouth irritation, poor oral hygiene. These are all factors associated with getting oral cancer, right? So what are the symptoms of oral cancer, right? So as we discussed, there are a lot of subsites in the oral cavity. By subsites, I mean a lot of parts. We unnecessarily use a lot of technical catchphrases in medicine. So there are a lot of parts of the oral cavity, and pretty much all of them can be involved by oral cancer. So what are the symptoms? So how do you know that, you might have something that resembles oral cancer? So quite commonly, you can have a white patch or a red patch on the tongue, on the roof of the mouth, under the tongue, on the cheek, or on the gum. So these patches typically are white or reddish, and they don't go away even if you rub them. We call that a leukoplakia. Sometimes they can be flat, sometimes they can be elevated, right? But if they persist over 2-3 weeks, it's better to get it checked out. Some people present with an ulcer or a sore. So that's basically a sore on the cheek or the tongue or on the gum that doesn't go away after 2 or 3 weeks. It's not necessarily painful. A lot of these are painless. They go silently for long periods of time without you realizing anything is there. So they can be quiet for a long period of time, and they can present with pain only later. So a lot of people think that, if it's painless, it's probably not oral cancer. That's not true. You can also have, thickening. So you can have thickening on the lip, thickening on the cheek, thickening on the tongue. Sometimes you can have loosening of teeth. So if if you thought your teeth were all right and you have a tooth loosening and falling out and you have some kind of swelling on the gum, that can also be a presentation of oral cancer. Another way is if you have swelling in your neck, right? So you have the lymph nodes or the lymph glands in the neck, right? So these are often involved by oral cancer when the tumor spreads to these. Some patients don't find anything wrong in their mouth, but they can find a lump in their neck. And when the lump gets tested, it turns out that they have oral cancer, right? So how do you get tested, right? So, you have a patch in your mouth or you have a sore in your mouth and you're wondering, okay, This could be cancer. What do I do? So it's important to find somebody who treats oral cancer, somebody who's experienced in treating oral cancer. The reason for this is uh, you want somebody who will be able to diagnose you. Because if you don't see oral cancer a lot, it can be quite confusing, even to train dentists, even to train doctors. Unfortunately, sometimes we miss it because it can present in so many ways. There's no absolutely typical way that we say a case of oral cancer presents. It can look like 100 different things. So it's always better to get seen by somebody who deals with cancer on a daily basis. What that person will do is they'll take a small piece of the tumor and send it for testing. We call that a biopsy. We break off a small bit of the tumor and we send it away for testing. And we also do something called scanning. So scanning a CT or an MRI scan will basically tell us how big the tumor is, what it is involving in your mouth, and if it's spread to the neck nodes. So this helps us plan your treatment, and that will help us know what type of cancer you have and what stage of cancer you have. So that gives us more than enough information to share with you. So you know what to expect as far as treatment goes, as far as cure rate goes, as far as complications go. Okay. So usually all of this can be done fairly easily. In a day or two, you can get all of this work done and you will have some clarity on, what to expect. So how do we treat oral cancer? So that's the next question. So oral cancer is one of the cancers that we treat very well with surgery. As a surgeon, all day I see people who don't want surgery, but unfortunately, surgery is the best way to treat oral cancer. We treat a lot of other cancers with chemotherapy and radiotherapy and they respond beautifully. But surgery is one of the best treatment options for oral cancer, and it's the one that we prefer. So the principle of oral cancer surgery, so what we aim to do is we plan to remove the tumor along with a cuff of normal tissue. So it's not just the sore that you see or the ulcer or the reddish area or the whitish area. You have to remove a cuff of normal tissue around it, because that cuff of normal tissue can have small microscopic cancer cells that we miss. So it's really important that we remove it with a margin. So that's the primary difference between surgery for cancer and surgery for other things, is that when we operate for cancer, we need to remove that cuff of normal tissue in order to make sure that we clear the cancer completely. In most cases, we also have to remove the lymph nodes in the neck, right? Because there's a high chance that cancers in the mouth spread to the lymph glands in the neck, and unless we remove them, our treatment is incomplete. Now, as you can imagine, if we take a cuff of normal tissue, if we aim for 1 centimeter all around the tumor, in the mouth, which is a very small confined space, there's a lot of collateral damage, right? What I mean is if you have a 1 or 1.5 centimeter tumor on the tongue, you'll end up removing at least 4 by 4 centimeters, right? And they have to be removed this way, because unless we remove the tumors this way, we can't cure the patients. So the next step is, how do we reconstruct, right? So it's not enough to say that we remove the tumor and we remove the lymph nodes. As you know, oral cancer, the functions of the mouth are very, very intricate and very, very sophisticated, right? So the way we speak to people, the way we swallow, the way we taste, the way we kiss other individuals, all of these are very, very intricate movements. They're all very well coordinated movements. So our job as surgeons is try to reconstruct all of these functions. So it's important that after oral cancer surgery, that you are swallowing well, you're able to eat a good diet like you were before. It's important to speak well, not only to your family, but in front of others. You have to eat in public, right? You have to be able to express yourself, right? Because all of these cancers affect the way that we see ourselves and the way that the world sees us. So it's not just enough to treat the cancer. We have to treat the patient and we have to reconstruct all of these intricate functions. And the good thing is, treatment is quite advanced nowadays, and we're able to reproduce these functions quite well. So almost all of our patients are eating well and speaking well without any tube support. They're able to go out, go back to work, face everybody. It's a very, very important part of treatment. So treatment Options, as far as surgery goes, have expanded. We are able to operate on tumors that we wouldn't have operated on, 10, 15 years ago, because our tools have improved, our equipment has improved. Of course, our support, the anesthetic care, the nursing care, the ICU care, all of that has gotten a lot better. So we're able to offer the chance of cure to patients who we couldn't dream of treating 10, 15 years ago. Our reconstructive surgery has become very, very refined and very aesthetic, right? So before we were just looking to replace tissue with tissue. So what I mean is if you remove a chunk of tissue from the cheek, you just look at replacing it with some other tissue from elsewhere. But it's a lot more sophisticated now. We're able to do a lot of scarless surgeries, so no scars on the face. So many of our patients, you can tell that they've been operated before. And we're able to do a lot more sophisticated reconstruction of the jaw. So when we lose, the jaw and we lose the teeth as a result of oral cancer. So if you look at these images, you're always pretty much very close to teeth, except if your lesion is on the tongue and your tongue is movable. If you have a cancer on the tongue and you can move the tumor away from the teeth. If it's anywhere on the floor of the mouth, which is under the tongue, it's on the hard palate, the roof of the mouth. If it's on the cheek, it's always very close to teeth and it's always very close to the jawbone. So when we go 1 centimeter away from the tumor, we end up having to sacrifice jawbone because unless we operate this way, we can't get rid of the tumor. So when we sacrifice jawbone now, we're able to do something called virtual surgical planning. So what that means is we take your scans and we perform the surgery on you virtually first. So before we take you to the operating theater, we perform the surgery. We decide where exactly we're going to cut, how we reconstruct that. So very often we use bone from the leg, how we would place that leg bone in place. So we're able to reconstruct your jaw, how exactly we put in dental implants. And sometimes we're able to do this in a single stage. So you go to sleep on the operation table. And when you wake up, even though we had to remove most of your jaw, you wake up with a fresh set of teeth and a new jawbone, freshly reconstructed. So these are things that we couldn't dream of doing, I guess, 15, 20 years ago. But with technology, with training, with expertise, we're able to do a lot. So I guess one thing I'd like to tell all of you is if you do have an oral cancer, please make sure you get evaluated. Please make sure that you explore all treatment options, because many patients, don't seek treatment because they feel hopeless. They feel that, okay, they're going to lose a lot of function. They're not going to be able to be cured, but that's not the case anymore. We're able to do a lot of sophisticated surgery. We're able to do a lot of sophisticated treatments to get the cancer out and also to get patients back on their feet. So we don't write off any patient, without doing a full assessment. And even if we can't cure patients, there are a lot of things that we can do that we can help them with. So unfortunately, we can't cure all cancers. We wish we could, but some of the diseases are too advanced. They've spread elsewhere. But the treatments that we help them with can ensure that they have what's called quality of life. So what we mean by quality of life is that every patient, even if we're unable to treat them for cancer, should be pain-free. They should be able to eat. They should be able to speak and breathe normally as far as possible. And they should have a good quality of life. By that, they should be able to enjoy their life. They should be able to interact with others. So there are a lot of things that we can do that can help out patients. So it's always important to get evaluated by a specialist and understand what your treatment options are. Is cancer of the oral cavity or the mouth curable? So yes, it is very curable. The vast majority of patients are curable. So we are able to offer them cure and they have a good chance of being cured. The caveat here, I guess, is what stage you seek treatment. So if you come with an early cancer, so if we say a tumor that is less than 4 centimeters in size, if you get treated at that point, your chance of cure is as high as 80%. So the vast majority of those patients get their treatment and they get cured. If you come with late stage disease, So if you come with stage 4 disease, if you come with large tumors involving the jawbone, your cure rates fall to 50%. But unlike other cancers, in mouth cancers, even in stage 4 disease, we're able to cure half of the patients, right? So this doesn't happen in other cancers. If you have, say, a pancreatic cancer, or you have a colon cancer, or you have an esophagus cancer. So an esophagus is the food passage. So if you have a stage 4 disease there, the likelihood of curing someone is very low, unfortunately. But with oral cancer, we can still cure patients with stage 4 disease. So it's very important at whatever point you are to go out, get evaluated, and see what your treatment options are. It's important for you to take the decision. Okay, so you shouldn't let anybody else make the decisions for you. Your doctor can just give you the options that you have, and you take the decision. But it's important always to have all the information, right? So the next point, I guess, is tobacco cessation. So what is tobacco cessation? So India obviously has an epidemic of tobacco usage. 1 in 3 adults uses tobacco. So it's important that we realize that tobacco affects virtually every system. It causes cancer, it causes heart attacks, strokes, it affects virtually every system. It's really important that we understand how important it is to quit tobacco. It's very important to understand how we quit tobacco. So we quit tobacco best with professional help, right? A lot of it is counseling. You have other aspects like nicotine replacement, so that can help you with cravings, and there are also medications that help you out. Lastly, what is screening? So screening is when we take patients without symptoms and we look at them and see if they have cancer. So for oral cancer specifically, it's important to get screened if you have a history of use of tobacco and alcohol, right? So both of these have a high risk of causing cancer. So go in and get an evaluation. If you get a cancer picked up early, it can be treated very easily. So you end up with a minor small procedure. You can go home in a couple of days. You have a very good chance of cure. But if it's detected later, the cure rates fall. The complications associated with the cancer and the treatment are much higher. So anything that looks fishy in your mouth, so whether it's a white patch, a red patch, any area that's raised, a loose tooth, lumps, bumps, anything that's lasting more than 2 weeks, go and get checked out by an oncologist. Don't sit on it. Don't neglect it. It'll probably save your life. So that's it from me. So I'm happy to take any questions, any comments.
Thank you very much, Dr. Subramaniam, for this presentation. I think very detailed presentation. And we have a few questions that have come in. Some have come in by the Q&A here, and some have come by SMS and WhatsApp to us. Can I start with the questions?
Yes, please.
So this is a question that you mentioned about tobacco cessation. There's this person who said that I have given up tobacco, given up smoking in my early 30s, but I now do smoke once in a while, perhaps a cigar. Is there any reason for concern for me?
So, please stop. Any tobacco use is bad, right? And even if you completely stop tobacco use, it takes almost 10 years for your cancer risk to fall, where you're at level with people who have never used tobacco, right? So I know that it's very hard to quit smoking. I know that it's very hard to quit tobacco and alcohol. But as a healthcare professional, I've seen what it does. So the answer is, it's always better to stop it completely. If you like nicotine, there are other options, nicotine replacement therapies and things like that. But no good can come from smoking. Even if it's once in a while, it is basically poisonous. It's noxious, it's bad for your system. So I really can't say that it's okay to do once in a while, because it's really bad for you. So I would say you've done a great job that you've cut down, but quit completely, because that's the only way that your cancer risk is going to fall to 0.
Thank you. I think your message is very clear. There's a question from Jyoti Vora, who asks, does chronic sore throat, is that an indication of for oral cancer?
No. So when we talk about oral cancer, we talk about the oral cavity. We are talking about the front. So we're talking about the part that's in front of the throat. So when you have a chronic sore throat, it's important to get it evaluated. That can sometimes cause problems in the voice box. So, a chronic sore throat can be a symptom of laryngeal cancer. So the larynx is the voice box. The hypopharynx is a junction of the voice box and the food passage. So it's important to get that area evaluated if you have a chronic sore throat. So it's not oral cancer. We call it the oropharynx, which is the passage behind the mouth, but it's important to get that checked out.
And so if somebody does have a gruffy voice, is there a reason for concern?
So if there's a recent change in voice, definitely. So if you've always had a gruffy voice, some people, so those variations are normal. It depends on, for example, your build, the structure of your voice box and things like that, how long and thick your vocal cords are. But if you had a change of voice for more than two weeks, please get it checked out, right? Because that can be something wrong with your voice box. It may not be cancer, but again, you have to rule out cancer, especially if you have a history of tobacco use, alcohol use, any of those things.
Thank you. We have a question from an anonymous attendee. Says, I'm 84, no tobacco usage at all. Oral cancer detected on March 3rd, 2022. One doctor gave an opinion for surgery along with plastic surgery, lasting for around 8 hours. 3 or 4 more doctors gave an opinion that no surgery and stick to medicines only. We suggest, this is actually from somebody who's asking for her mother, who's 84. We suggest want to minimize the suffering for my mother.
Absolutely. So I guess this is an area that's quite close to my heart. So, we've treated a lot of elderly patients. We published a lot of data on treating elderly patients with head and neck cancer. So right now, the way I look at it as a surgeon is age is just a number. You have 84-year-old patients who look like they're 64, their blood values and the way that they move around and how they take care of themselves. And of course, you have 64-year-olds who look like 84-year-olds, right? So oral cancer is one of the nasty ones, right? So unfortunately, if you don't treat it on time, it becomes painful. It starts bleeding. After a while, it becomes difficult to eat and speak and talk and all of those things. And it becomes quite miserable. So to be completely honest, the oldest patient that I've operated with oral cancer is 93 years old. She's doing well. But we have to pick patients very, very carefully. So we pick the patients who are over 80 very carefully. We do a thorough assessment. We make sure they're fit. We make sure that they're motivated, that they do the rehabilitation, and that we should be able to get them back on their feet. So, just by being 84, I wouldn't say that, your mother is not a candidate, but I would say get evaluated, have a discussion, because just medications alone are not going to do anything. And if she's healthy, if she's fit, if you think that she can go through surgery, it's always a better option, because otherwise it's a very painful and miserable situation with an advanced oral cancer. And it's a slowly progressing disease. It's not a disease that, takes away patients quickly. It can be quite long-standing and painful. So if she's fit and if she's motivated for the treatment, I would say look at the option of treating it. There are some surgeries we can do that reduce the risk. So even if we don't do plastic reconstruction, microvascular reconstruction, we can take tissue from somewhere else, reduce the duration of surgery. But I think both are reasonable. But I think explore the option of surgery fully and see if she's fit. It depends on whether she also has any other diseases. Is she diabetic, hypertensive, any heart trouble, those kind of things. If that's not the case, then I would advise palliative radiotherapy. So radiotherapy is an option we give to patients who don't, get surgery. They're not candidates for surgery. So radiotherapy can slow down the disease to some extent. It can't cure the disease, but it's still a better option than tablets and medication.
Doctor, there's, as this question indicates, there are varied opinions that are available to this person and for her mother.
Absolutely.
What does a person do in a case like this? As she mentioned, there's one doctor who said surgery, there's plastic surgery, 3 or 4 more doctors said no surgery and just stick to medicines. So what should a person do in situations like these?
So I guess it's not the patient's problem, it's the doctor's problem, I guess. So how we minimize this confusion and how we minimize this lack of clarity as oncologists is we do something called a multidisciplinary tumor board discussion. So what that means is we have people from different cancer specialties. So I'm a surgeon. I'll sit down with my radiation oncologist and my medical oncologist, and we'll sit all together and we'll say, okay, for this patient, what is the best possible option? Is this patient going to be a good candidate for surgery, or do we think they're not going to recover? If we think they're not a good candidate for surgery, is radiotherapy good? So we come up with a joint discussion and we come up with a joint recommendation. So the final recommendation that goes to the patient is coming from multiple doctors, because obviously it's a very subjective thing. You can imagine that if even if you go to 10 mechanics for your car, you're going to get 6 different opinions, and the human body is a lot more sophisticated than that. So having a joint discussion and having a joint recommendation is always good, and that's what we try to do in cancer centers. So I think that's helpful. I think
this person has said that my person is otherwise fit but a weak personality overall, no other disease. So is radiation better than medication? And the next thing that she has said is that biopsy made her so weak that we feel that she cannot withstand an 8-hour surgery.
Okay. So I understand your point. You're worried that she may not withstand the surgery. If you go to an oncologist who says that, okay, fine, let's make an independent evaluation. Let's show her to the anesthetist. Let's see what the anesthetist feels. So there are two aspects here, right? So one is being physically fit to go through the surgery. And another aspect that you brought up, I guess unintentionally, which is very important, is the psychological trauma that people go through, when they're diagnosed with cancer. So cancer has a lot of stigma. There's a lot of fear attached to it. So if any of us hear that we have cancer, the first thing that we do is we feel helpless, we feel depressed, we feel that there's no way out. So it's important that she probably has a discussion with somebody to see if she's having symptoms of depression. It's not uncommon. So if we treat 100 patients with cancer, 30 of them will have depressive symptoms at some point or the other. So once she has that discussion, you talk to her, your oncologist talks to her, you make her understand, okay, you do have cancer, but it is treatable. We can do very good things for cancer today. We can control it. We can potentially cure it, but you have to look at the long term. You have to think positively that you're going to get through the treatment. So this is what I tell all my patients. You need to be positive. Whatever support is required is available from your healthcare practitioners, but we need to be in a position where we take the treatment and we get through it. So if she's having depressive symptoms, please show her to a psycho-oncologist. So a psycho-oncologist is a psychologist or a psychiatrist. So that's a mental health professional who specializes in cancer. So they know especially what patients of cancer go through, what kind of mental trauma and agony they go through. Have a discussion with her. Make her understand that it is very treatable, potentially very curable, and she will get through this, and try and understand what she wants. If you feel after all this discussion, after giving her some time to deal with all this, that she's willing to entertain the idea of surgery, that she's willing to entertain the idea of cure, then, ask your surgeon to walk you through it, discuss, what the complications are, and let her take a decision. But very often in that initial phase, when we find out that we have cancer, people are very upset. They're not able to make a clear decision. They're not able to have a lot of clarity.
Right. Doctor, we have got a question from somebody. I think we've already answered this question about tobacco being the only reason for oral cancer. Mr. Prasad, if you go through the presentation once again, which we will have on our website on Monday evening and Tuesday, you can have a look at the presentation once again, as well as takeaways from this session, and you can have a look at that once again. Doctor, we have a question from someone. There are 2 questions. One is, Doctor, are you available for a teleconsult or for a second or third opinion?
Sure, no problem. So you can reach me through my website, which is drnarayana.in. Not an issue. So drnarayana.in. You can find me there. Not an issue. Happy to help.
Right. And the next question and the last question that we have is, my father, age 53, has oral cancer surgery 2 months back. His jawbone has been removed on the right side, and now the doctor has suggested radiation with chemotherapy. The question is that necessary?
So in a word, yes. So when we do cancer surgery and we remove the disease, when it's an early stage disease, right? So when it's a small tumor, it's less than 4 centimeters, the lymph nodes are not involved, then there's a very high chance of cure. So we remove the disease, we remove the cuff of normal tissue, and the patient's okay. When you have advanced stage disease, right? So when the jawbone is involved, when the lymph nodes are involved, even if you do a great surgery, you remove everything, you remove a cuff of normal tissue. The reason why we give radiotherapy and chemotherapy is because there's a high chance that the disease will come back. So as surgeons, we can remove whatever we see with our eyes and whatever we can see on the CT scan or the MRI or the PET, whatever you've done, but we can't see those microscopic cancer cells, and it becomes impossible to remove them, you know? So radiotherapy and chemotherapy have their side effects, but they've enabled us to do surgeries and cure a lot more patients, you know? So you've gone through the surgery, you've struggled, you've gone through the rehab. I'm hoping that your father is in a good shape now. He's eating, he's following. But if we don't give him radiotherapy and chemotherapy and the disease comes back, then unfortunately it all goes to waste. So we don't take this decision of giving you then more than one form of treatment lightly. So no oncologist takes it lightly. You know, we don't do it. Uh, we don't take that decision lightly, and we don't say it casually. If they've asked you to take it, please take it, because you've been through the surgery, you've gone through all of that, you've recovered. Now, if the disease comes back, it all would have been wasted, you know? So whatever the issue is, it can be managed. So if your father has pain swallowing, you know, there's swallowing therapists available. If he has skin reactions, there are good treatments available for that. If he's feeling upset, depressed, dejected, there's good treatment available for that. So I think a lot of supportive treatment is available. Reach out to whoever is treating you. It's important that you have that wide base. You have a lot of different people who are taking care of him, but please get the treatment because you've gone through the hard part. Now just make sure that he's disease free and he's cured.
Right, absolutely. And I've also, copy pasted something from your website for
Thank you.
in-person appointments, etc. So you could have a look at that. And as I mentioned earlier, this entire video webinar that we've had will be on our website on Monday evening, perhaps, as well as takeaways. And the takeaways that we publish, as people who are regulars know, is written by a qualified doctor. So these are informed takeaways. And as it's mentioned, it's not just a transcription of whatever doctor has said. It's takeaways from the session. So that's what we publish after every session is over. And that will be there on our website, which is seniorstoday.in. Thank you very much once again, Dr. Narayana Subramaniam. And the next time we get you here, we'll also talk about music.
Sure, anytime. So the reason why I don't talk about music is because I'm more of an amateur when it comes to music and more of a professional when it comes to surgery. But why not in the future? Thank you very much for having me.
Thank you very much. And those of you who are regulars, if you want us to keep you informed about, pre-register you for our forthcoming health webinars. The link is there in the chat window. You can just fill up a form, and henceforth you don't have to register or look out for our notices for this session. And while we thank Dr. Narayana Subramaniam for being here, we will be back once again next Saturday on at 5 p.m. for our session, which is Health Live at Seniors Today. The rest of the week, we have our various activities. Tomorrow is Group E of Seniors Have Talent Dr. Subramaniam, I must tell you that we have every Sunday, we do this session with senior citizens. All of them are 60 plusers, and some of them are there here, and they are singing away. And there are, I must tell you, you would be glad to know there are a host of people from Bangalore who participate in our
Wow.
Sessions, and from southern India. And these are amazing because you have people who are 60 plus, and clearly music is huge for them, and they are not just hobbyists. They have advanced level stuff. They have karaoke. They are into into good technology. So something for all of us to get inspired by. Thank you very much once again, Dr. Narayana Subramaniam, for this session on oral cancer. Thank you very much.
Thank you. It was a pleasure.